Chapter 6, Exposure Control, Barriers for Patient and Clinician. In this chapter, we will be discussing infection control, personal protection for the dental team, clinic attire, use of face mask, respiratory protection, use of protective eyewear, hand care, hand hygiene principles. We'll also discuss methods of hand hygiene, gloving, latex hypersensitivity, documentation, everyday ethics, and factors to teach the patient. Our learning objectives for this chapter is that the dental hygiene student will be able to define key terms and concepts, explain rationale for exposure control, identify criteria for barrier selection, explain rationale, guidelines for hand hygiene, and identify clinical manifestations and management of latex sensitivity. Again, we did go over this in 219, so I'm not expecting to spend too much time on this. All right, infection control. Our big thing is standard precautions, right? It is a set of infection control practices used to prevent transmission of diseases that could be acquired through contact of blood, bodily fluids, intact skin, including rashes and mucous membranes. And you think of where we're working and we're touching a lot of this, right? So we do have an obligation to our patients to protect them from transmissible diseases in the office. Personal protection, we have been doing this from day one of preclinic, right? Think of all of our personal protection. And, you guys came in right as things were changing. So this is going to look a little bit different on here. I did add a couple things regarding COVID in there, since it's not ever really going to go away, right? Just like influenza, we have it. It may be a seasonal thing. But we'll talk about that a little bit. So it is important that the dental hygienists protect themselves so they can protect their patients. One way of doing that is through immunizations. Excuse me, sorry, my throat is like really sore today. So when we're working in the dental setting, it is our job to protect our patients. So they recommend that the dental hygienists and any healthcare workers get the hepatitis B vaccination, influenza, measles, mumps, rubella, pertussis, varicella, and then I added that we are going to probably be asked to also have the COVID vaccination, right? It is becoming more apparent that it will be expected of healthcare professionals. At the time of employment, it is reasonable for an employer to request your current immunization records and also ask for specific tests such as your TB test, the Manitou test. The needs are going to differ depending on where you're working and your population, right? So you want to make sure that you maintain your records on a regular basis, keep everything up to date, go in routinely for your physicals, and get those boosters and reimmunizations to keep both you and your patients healthy. So just so you know, loss of work, personal suffering, long-term systemic effects, and exclusion from continued practice are all possible results of communicable disease infection for you and for your patient. So think of that patient that's struggling to get by, but they still came in, and you didn't get your immunization, or you didn't get, you didn't stay home when you were sick. You're going to then pass that on to them, and they may be more severely impacted than you would be by not coming into work. All right, clinic attire. Yes, this has changed a lot. I shouldn't say it has changed a lot, but more is expected from us now. So clinical apparel for clinicians is to prevent contamination, right, from splash, spatter, aerosols, and patient contact. One thing this chapter doesn't go into is ear protection, and when we're using ultrasonics, that is becoming more and more of a concern. Hearing is becoming more of a concern for those who use ultrasonic kind of full-time. So that might be something that your office may require you to get, or you may want to get. So standard clothing, scrubs should not be worn in the at home or coming in, especially if you're stopping at the gas station or what. But you don't want to leave with it if it's exposed, because you can get it in your car and then you touch your car seat and all that good stuff. So clinic attire and shoes are not to be worn outside the clinic practice setting. I still, I would like to see students changing in the bathroom, especially during COVID, but I know that it's difficult, but I think it's worth it. When clinical attire is worn outside, contamination can be carried from and brought into the treatment rooms. Okay, so you can bring it into there. You can also bring it home. Protective clothing, such as gowns, we now have our, they're no longer disposable gowns, our regular gowns, and they are designed to be worn over clinic attire to protect the skin and also protect your clothing. So now that we're wearing those longer gowns, those are what are going to be maintained outside of the office. Excuse me. The gown or jacket needs to be closed at the neck and fastened in the back. The fabric is, in our clinic, is reusable, but as you know, there are some disposable ones. And it needs to be stain and fluid resistant. These should be washed, or must be washed, actually, I would say must be washed commercially and withstand washing with bleach. The garment must cover the knees when seated, and sometimes these will be questions on boards, or even if you're taking a CE class, you need to know that these need to be to cover the knees when you're sitting. Long sleeves with cuffs need to be worn. If it's soaked or soiled by infectious material, you need to change it immediately. All right. Hair is to be worn off the shoulders and fastened back away from the face. Because the hair is exposed to contamination, an appropriate head cover is advised when using handpieces and ultrasonics or air polishing. So once you get into those ultrasonics, use your head coverings and make sure that they are being washed in bleach. Facial hair needs to be covered with a face mask and face shield. Okay, so we used to not provide face shields, but obviously now you've all received one, and they've gotten actually quite reasonable. So I know Costco, you can get just a ton of them for, I think, 10 for $10 or something, and they last quite a long time. All right, use of a face mask, respiratory protection. I find it so interesting that this book was written before COVID hit, but yet it's still addressing so many of these things. It's almost like they saw it coming, and the CDC saw all of this coming. So respiratory protection, aerosols. We know that they can remain in the air for up to 24 hours. They're small particles that you're going to breathe in, and they bury themselves down into the lungs. So dispersion of particles of debris, such as polishing agents and calculus, are all considered contaminated. And those all happen regularly in our office, right? So aerosols are created after using our ultrasonic, a handpiece. You guys are going to be using a handpiece next semester. Removing, adjusting sealants, and then removing, oh my gosh, ortho cement. Okay, so start thinking about this stuff. Okay, hopefully you'll be able to use the ultrasonic scalers soon. Evidence of the spread of particles appears on the splashed face, protective eyewear, and uniform and on the barrier. So be careful when you're touching your gown. I see so many of you guys touching your gown with your gloves and with your hands while you're talking to your patient. But that gown is dirty, and it's getting aerosols from, we have an open clinic. So think about all the aerosol that could possibly be going on your gown, and you're touching your hands on it. Touch your hands together in front of your face. Fold your hands. Don't touch your gown. All right? And then we should be putting up barriers on everything, wearing our PPE to protect our patient. Now, mask efficiency, we have the filtration, which is measured in BFE, which is bacterial filtration efficacy. And that is just a measurement of the mask's resistance to bacteria. Okay? So we've heard so much about these N95 masks, and that is a surgical mask that covers the nose and the mouth, and it has 95, that's why we have N95, BFE, okay? Airborne droplets less than 3 to 5 micrometers in size can reach the alveoli in the lower respiratory tract and may potentially cause infection. That's why we want our N95s. Okay? Droplet nuclei. So think of, when you hear droplet nuclei, think of tuberculosis. And those range from 0.5 to 1 micrometer and are used to, are a risk to the healthcare professional. So when you're thinking about that, think of what kind of PPE you need depending on that airborne size, right? So we have droplet nuclei, 0.5 to 1. That's pretty crazy. Moisture absorption, so soaking through the lining of the mask. You don't want to be careful of that. And then comfort, you want to make sure that they're comfortable enough to wear. I know right now things aren't as comfortable and as perfect as we want it. And who knows what it's going to get, but we have great engineers all over the world that are working on making things better for us. Materials, various materials have been used for masks, including gauze and plastic foam, fiberglass, synthetic fiber mat, paper, even more so now than ever. So lots of different products that are being made. The use of a mask, make sure that you're positioning the eyewear before, so you're going to adjust the mask and position the eyewear before you wash your hands, right? We're going to wash our hands after everything is in place. Okay? All right. Use of protective eyewear. This has become really important. Also, I had to go online to find a picture for this, and you can see them putting on a face shield with loops. And I know that it's difficult right now, but I feel like it's been a long time coming, that dental hygiene should have been doing this a long time ago. Okay? So we want to prevent any eye infections, any eye accidents, because it can lead to a lot of pain and discomfort, lost time from work. Think of your patient too, making sure that they're getting their protective eyewear. And accidents can happen at any time. I've told you guys about the classmate of one of my friends, how they were using a scaler and their patient didn't have eyewear on, and their scaler went right up and scratched their eye because they didn't have a great fulcrum. So accidents, they happen, but you need to be prepared for that. And that's why we wear PPE and we give our patients protective equipment also. Again, contamination can happen through saliva, through our plaque biofilm, our dental decay, pieces of old restorations, those dentures, right? All of that, calculus, ton of bacteria in there. And all of that can be aerosolized by using your air water syringe, by using a handpiece, by using your Cavitron or your ultrasonic. So just be very deliberate in your techniques and your instrument management, your patient's prosthetic management, and also how we are evacuating that, using that HVE to prevent it from going in the air. So indications. Dental team members, we're going to protect our eyes, right? And prevent infections and injury. General features of acceptable eyewear. We want them to be lightweight. Some of you who have loops, you notice that difference between the loops in your eyewear, and even loops to loops, brand to brand, frame to frame, whether or not you have a light or don't have a light. You also want them to be shatterproof. You want to have sufficient covering with side shields. You have to have side shields on. And they should be flexible with round, smooth edges to prevent any discomfort. And big thing, make sure that we can disinfect them. Okay? Other things to consider is your loops. If you are wearing a face shield, can you see through that? Does your light fit on the face shield? They're coming up with all sorts of things, but I just want you guys to really be thoughtful when you're thinking of protective eyewear, and that does include your face shields. Types of eyewear, we have goggles, we have eyewear with side shields, we have just the plastic side shields, to go on the glasses. Eyewear with curved frames that protect, instead of having side shields, it just kind of wraps around your head. So lots of different options. We have our loops, there's child size, adult size. All right, now let's talk a little bit about face shields. We need to wear a face shield over a regular mask when aerosols are being produced. I don't think this was in the last book, but now they're saying we need to wear a face shield with our ultrasonic use. Okay, so think about that, how things have really transitioned. And I think the reason why face shields, it was recommended, but it wasn't like you really need to. Now think of air polishing or power polishing, some of them call it, where you have those fine particles in the air and how that can affect your lungs by breathing that in. Protective eyewear for patients. We want to make sure that they are being protected. Sunglasses are nice if they aren't having nitrous. Sunglasses are nice to protect that photosensitivity in their eyes. And then just make sure you have a couple different sizes. All right, so contact lenses. Dental team members may wear contact lenses, but they still need to wear protective eyewear over them. Care for your protective eyewear. You want to run it under running water to remove any abrasive particles, because if you're rubbing it first, you're going to scratch the surface, right? So try and rinse off all the particles first, and then you can go ahead and disinfect it. Check periodically for scratches on lenses, especially with your loops. And eye wash stations, make sure you know where they're at. You should know those. We have gone over that a couple times in our clinic, but make sure you are always aware in every office you work in where the eye wash station is. And just know that it must be connected to a regular faucet. It should not be connected to a regular faucet because of the hot water that comes out of a regular faucet. You could burn the eyes. Moving on to hand care. This is a huge part of breaking that cycle of transmission, right? Hands, especially under the fingernails, serve as a very welcoming home for microorganisms, a reservoir. Also breaks in the skin. Make sure you're moisturizing your skin. I know Aquifer at night, put some socks on your hands. That will help keep your skin nice and intact. If you do have a break in the skin, wearing a Band-Aid along with gloves, give it that extra protection. So conscious efforts should always be made on gloved hands. You don't want to touch anything that's dirty, right? So bacteriology of the skin, resident bacteria mainly relatively stable unless there is a break in the skin. Generally, they tend to be less susceptible to destruction by disinfection procedures. The resident bacteria does. Then we have our transient bacteria, and that just kind of reflects the continuous contamination by touching things. Okay? Then we have, I guess that's our main two. So we have resident bacteria, that's what's normally just there, and then we have transient, and that's from touching things. Hand care, make sure you're getting under your fingernails. OSHA and actually the CDC says that you need to have clean, smoothly trimmed, short fingernails. And they also even go as far to say to make sure that your cuticles are well taken care of also to prevent any breaks, right? So when we talk about short nails, it makes hand washing a lot easier. It also can't harbor as much bacteria. Long nails can cut and break the gloves open. And then you often would have to wear a larger glove if you have long nails. So that's why they're recommending the nice short trimmed nails. It's also going to give you a lot better dexterity on instrumentation and decrease the chance of you digging your fingernail into the patient's gingiva. So I'm not sorry to say, I was going to say sorry to say you have to keep your nails short, but short nails, I get so grossed out when I see long nails. I just know how much bacteria can be under there. So some of you wonder, why can't we have artificial nails? They are associated with fungal and bacterial pathogens in hospital settings and are not recommended for clinicians. Okay, this includes gel. Even though gel isn't artificial, you still cannot wear gel. Because of the application process and the roughening of the fingernail, when they come off, they cause a lot more problems they create, again, another reservoir for bacteria because of that rough surface. Wearing rings and nail polish isn't recommended because chipped nail polish and skin under the ring may harbor bacteria. Wristwatch and jewelry. Remove hand and wrist jewelry at the beginning of the day. Microorganisms can become lodged in the crevices of rings and of your watch. So think of bringing that home to your loved ones. Gloves, after hand washing, put on your gloves. Never expose open skin or abrasions to a patient's oral tissues and fluids. After the gloves are removed, you need to wash your hands. I see you guys really slacking on that lately. Taking gloves off and not putting any hand sanitizer or soap. Remember, we want to use soap right now rather than hand sanitizer because hand sanitizer is getting so hard to find. All right. Moving on. Here's just a reminder of how you should be doffing your gloves, okay? And then different types of hand hygiene methods, and it, go through the purpose, the duration of each of these. Okay, remember ours is a modified surgical hand scrub, so it's kind of between the antiseptic wash and the surgical. All right, you do need to know these for your boards. Don't memorize it, but what makes each one different than the other, and when would one be used over the other. Okay, rationale, purpose, and facilities. Hand washing principles. Rationale prevents the spread of bacteria, right? So this is one of our biggest breaks in that cycle of infection and transmission, I should say. All right. You want to remove the surface dirt and transient bacteria. You're going to dissolve the normal greasy film on the skin. And then you're going to rinse and remove all loosened debris and microorganisms. So that's kind of what we're doing on our first rinse. And then our second one is what really gets us clean. So the first time we're removing debris. Second time is when we are basically killing all the bacteria. Okay. So where do you do this? You do this at a sink, right? And you should have a foot pedal to turn it on. If you don't, you need to find a barrier to turn the sink off, or the faucet off and on. For regular sinks, again, using a barrier, use your elbow, whatever it takes to turn it off and on without contaminating yourself. Soap, you want to use liquid soap, not a bar of soap. Apply from a foot or knee activation or electronically. If that's not available, again, maybe you want to consider using a paper towel to push down on that soap dispenser. Again, you are placing the soap on after you're lathering, after touching it, so it's usually not a huge issue. Scrub brushes. I love scrub brushes. The only problem is that sometimes people over scrub and end up causing lesions on their hands. So you just want to be careful of that if you decide to incorporate a scrub brush into your hand washing protocol. Methods, let's see here. Indications before and after treatment. Every time you unglove or reglove, you are going to wash your hands. Anytime you see a puncture in your glove, you're going to, or break in the glove, rip in the glove, you're going to wash your hands. Okay? After barehanded touching inanimate objects, wash your hands. When hands are visibly soiled, wash your hands. Before leaving the treatment room, wash your hands. Okay? We are always washing our hands. But I also want to remind you to be very mindful of when you are donning and doffing gloves. Okay? You want to minimize as much as possible, and it's not just always to preserve gloves like it is right now for COVID. I think you're learning really good skills about that, but when you go into practice, that employer sees those gloves as a cost, especially right now. They're much higher priced. And if you're constantly taking them off and on, not only do you have to wash your hands every time you take them off and put them on, which is going to destroy your hands from all the washing, you're also costing them a lot of money. And so I know I one time worked in an office that was very strict on the number of gloves that you can go through. They wanted you to think critically. When are you going to change your gloves? They were very mindful of how many times you are changing your gloves with each patient. So be aware of all of this. This is out there. It is still a business, as much as we like to just think it's just taking care of people. There's a business side to this, okay? So descriptions, we have routine hand wash, and that is sufficient for routine dental examinations, okay? Non-surgical dental procedures. You're going to wet the hands, apply with water. You're going to apply the soap and non-bacterial soap or plain soap. You just want to avoid hot water. Remember, hot water is opening those pores in the skin. Rub hands together for at least 15 seconds and cover all surfaces of the fingers, hands, and wrists, including under the nails. Each hospital or oral surgery clinic has rules and regulations for surgical antisepsis. These will be posted over the sinks. Okay, a surgical antisepsis performed as the first one of the day will be 10 minutes, and subsequent ones every day will be 3 to 5 minutes. Okay, this is in a surgical office. So you guys can review the steps in that, but like they said, you're going to have more of a display in front of you showing you how you need to do it. But we know that we need to lather. A lot of people will hand sanitize after they have done their surgical wash, which I always find interesting. Okay, so you're going to wash your hands, making sure that there's a nice lather. You're going to get both sides of the hand. You're going to interlace your fingers, clean around the thumbs. Use an orange wood stick, just like we're using a sterilized orange wood stick to clean around the nails. So the first hand, you're going to lather the soap, increase the exposure time to the antimicrobial agents within the soap, and apply surgical liquid antimicrobial soap with a brush. All right. This is the part, this is where it's modified for us. We don't use the brush. You're going to get the first hand and arm. All right. Then you start to work on the second hand. Again, you're going to repeat everything that you did on that first hand. At the end of the time, you're going to rinse very thoroughly each arm and hand from the fingertips towards the elbow, and you're going to apply the towel from your fingertips, drying it down. You don't come back up and contaminate that those fingertips, okay? All right. Gloves and gloving. Inspect your gloves. That's the first thing I want to tell you, is make sure that your gloves are of good quality and they are going to protect you, that there's no holes. So when you put them on, make sure you look at them. All right, so with that said, we know that they are a very effective barrier between the patient's saliva and blood and bacteria and our bodies. Again, our skin is a great barrier, but this adds another layer of barrier that we don't, in case we have a cut or a break in the skin, okay? You want to look for strength and durability. You want to make sure that they are tear resistant, impervious to materials used during clinical procedures. If something that we use is going to break them down, we don't want it, right? Just like Vaseline. You want to make sure that they're non-irritating to the skin. So using non-latex is a big thing, okay? Because having an allergic reaction leaves you very susceptible to bacteria breaking through the glove and getting into your system. So the glove should also cover your sleeve cuff and should be pulled up over that, okay? Ergonomic choices, make sure that there's a good fit. Sometimes you don't have an option and it's kind of a one size fits none, but try and get as good of a fit as possible to help with that tactile sensitivity. So we have latex, we have non-latex, and we have non-sterile single-use examination in the treatment room. Pre-sterilized single-use, those can be latex or non-latex. For a long time, they were only latex. But our non-latex include our vinyl, our N-nitrile, block polymer, Neoprene, I've used neoprene before. So lots of different products to use out there for gloves. Now our heavy duty gloves, you guys have the non-latex, right? Those are our hand washing gloves. Those are our we call them the nitrile gloves, right? But we have patient care gloves that are also nitrile. We call those patient care gloves, and then we call our utility gloves nitrile. All right, and they are puncture resistant, and so that's why they are for handling those instruments. There's also plastic food barrier gloves, and sometimes places will have those to put over your patient care gloves while you're typing on a keyboard or such. So mask and eyewear placement, of course, you're going to put your gloves on after you have placed those and you have washed your hands. You always want to glove and deglove in front of the patient so that they don't need to worry about your use of gloves when you're using them, okay? Avoid contamination. Keep your hands away from your face shield, from your hair. You know, make sure that your face shield and your gloves are fitting well. I see you guys sometimes touching your hair when you're adjusting those, even though you don't try to and it doesn't feel like you touched your hair. More often than not, you have, and then I have to say, you know what, change your gloves. Change your gloves, change your gloves. And it's just so important that you understand about cross-contamination. Telephones, patient records, if you have paper records. The clinician's stool, make sure you're wiping your stool down very, very good between patients, but that patient doesn't know that you wiped that, so try not to touch it, okay? All parts of the dental equipment, okay? Torn, cut, or punctured gloves, you need to remove them and wash your hands, okay? Removal of gloves, I had the picture on a previous slide of how to do that, so please review that. Factors affecting glove integrity. A new pair should be used for every patient. And then you really typically don't want to wear them longer than an hour, and I feel like in our clinic we aren't really doing that because you guys are getting up and changing them for different reasons. Of course, with COVID, these things have been stretched a little bit because of the short supply, and we all want to get through school and we all want to keep our offices open, right? When the gloves start to develop a sticky surface, you want to remove and wash your hands, okay? Complexity of the procedure. If you're using instruments that could puncture or perforate the gloves, you probably are going to need to change a little more frequently, right? Make sure you know the size of your glove. All right. Storage of gloves, they need to be kept in a cool, dark place, okay, to prevent them from breaking down. Latex hypersensitivity. This used to be really common. Now latex isn't used much, but you can see where this would make an individual more susceptible to infection. So gloves that can be used in place of latex, again, any of those non-latex gloves, or neoprene, or nitrile, or vinyl, anything like that, okay? So know that this is due to direct exposure to the latex. Sometimes it's because of the powder inside, the cornstarch inside the glove, that people will have an allergic reaction. And sometimes it's the latex. So just so you know, it could be one or the other, so do some investigating. So type 1, you guys do need to know the different types of hypersensitivity and which ones are associated with things like dermatitis and stuff. So type 1 is immediate reaction, and you're going to see hives, or urticaria, dermatitis, a rash and itching, nasal problems such as sneezing, itchy nose, runny nose, watery eyes, respiratory tract, it might have difficulty breathing, asthma-like wheezing and coughing. Then we have, and also anaphylaxis falls under this category. Then we have type 4 hypersensitivity, which is a delayed reaction, and you're going to see contact dermatitis, and that develops over 8 hours to 5 days after contact. So individuals at high risk of latex sensitivity have had frequent exposure to latex products such as the dental healthcare professional. Not so much you guys, because you guys, everything's been removed pretty much from the dental office. But think of also patients requiring placement of rubber tubes or drains. So genitourinary, also think of prophylactic, prevention of pregnancy. Condoms often have latex in them, so we'd want to be aware of that. And then patients that have spina bifida also commonly have a latex hypersensitivity, allergy to bananas also. Bananas, kiwi, chestnuts. Do you guys remember that question from 2 semesters ago? So management, make sure you question your patient about allergies and then document any kind of anything that the patient reports and any type of reaction that you see. Appointment planning, when they do have a latex allergy, you want to treat them in a latex-free environment. So if you use latex in your office, they need to be the first patient of the day, because then there's no airborne latex. Clean the clinical areas, prepare the room. You must wear non-latex gloves when you prepare the room for these individuals. Just some things to think about. And then emergency treatment. Inform the entire dental team if there is an emergency. And have latex-free emergency card available. So equipment that might contain latex: bite blocks, blood pressure cuff, gloves, goggles, lead apron cover. Interesting, right? Mixing bowl. So when we are mixing our alginate next semester, is that made out of latex? Nitrous oxide nose piece. Ours are not, but know that some of them are. O-rings in the ultrasonic insert. Orthodontic elastics. Most of these have been replaced, but they're still out there some. Stopper and anesthetic carpule or cartridge. Ours don't have it. And then the suction adapter. So documentation, you want to document any irregularities related to protection, special needs taken for each patient, especially if they have a latex allergy, unexpected need for referral, especially think of tuberculosis, and then information in the medical alert that this patient is sensitive to latex. That way they can be scheduled easily at that first visit of the morning. All right, factors to teach the patient. When I first started in dentistry was when AIDS was still very scary, there was still a lot unknown about it. And then people started noticing that we're wearing more barriers, we're wearing our PPE, and they'd say, you don't need to wear gloves for me. I don't have AIDS. There's no chance I have AIDS. You don't need to wear that for me. You don't need to wear goggles for me. You don't need to wear that. And what they didn't understand is that we had to wear it for everybody because it was just really coming about. And we've come so far from that. Now it's just the norm, right? But the patients sometimes need to know why we have to wear this, wear all of our equipment. And it's to protect our health and their health. Teach them the importance of protective eyewear for them. Why is it? Well, we don't want them to get an infection in their eye. We don't want any foreign objects to land in their eye. And significance of hand hygiene and the control of disease transmission. That's an easy way to stop it. And that's not only for in the office, but just if we can educate everybody on good hand hygiene, we'll all be a healthier society. All right. I didn't talk about the first one. I just realized that health history, obtaining a good, purposeful, in-depth health history. Where are their allergies? Do they have allergies to kiwi? Do they have allergies to bananas? Then we need to watch anything that may have latex in it. Okay? All right. If you guys have any questions, please let me know through email. Thank you.